Hi, networkers. We are doing our second to last Facebook Live Journal Club video. I'm just waiting for Dr. Gundeep Sekhon to join us. She is actually just right here, and I'm just welcome back, everyone.
Hi.
Hi, how are you?
Awesome. How are you?
Good.
All
Thanks for
right.
joining us
Yes. It's
again.
wonderful to be back. Yeah.
Yeah. Just as a reminder, oops, excuse me. This is Dr. Gundeep Sekhon, who is a geriatric psychiatrist and works out in a correctional facility in California. So thank you. Tonight you're going to be talking about sexual function across aging, right?
Yes.
Okay,
All right.
great. Let's get started.
Yes. And this is the second to last.
Yeah, our last
Oh
one
my.
next week. We usually do Monday, Wednesday, but next week we
Yeah.
are just doing a video on Thursday night with Dr. Lisette Rodriguez Cabezas
Okay.
on an interesting topic, actually, women's mental health topic and
Oh,
ethics
wonderful.
issue. So, yeah.
Oh, great. All right. So we're talking about sexual function across aging.
Mhm.
The the title for me was misleading because I thought this is a geriatric psychiatry topic, but it actually talks about women's health.
Oh,
This was published in 2016 out of UVA in Current Psychiatry Reports. And the article starts with the various stages, reproductive stages, as well as social statuses that women go through, and hence how the sexual function changes because of that. It talks about the biopsychosocial and interpersonal aspect, and it starts with the sexual response. They start with the 1960s linear model that was introduced by Masters and Johnson. So first they're talking about desire, arousal, and orgasm, whereas the linear model talks about excitation, plateau, orgasm, and resolution. And there is talk about how the woman's or the girl's upbringing, the cultural expectations, the gender roles, interpersonal stuff, as well as medications, substance use affects the sexual response. It also talks about the circular model, which was introduced. So the chronology is that 1960s, Masters and Johnson talk about the linear model. 1970s, Kaplan talks about the cognitive aspect. And then by 1990s, the late 1990s, Rosemary Bazon out of Canada, she introduced the circular model, which introduces the aspect that for women, it is not a linear phase. It talks about intimacy, satisfaction, and other aspects. So in terms of the circular model, four things were differentiated. The article doesn't talk about it, but I think it is important to talk about. First is that there is a state called sexual neutrality that women can be in. For example, when they become new moms or they are busy in relationships, caregivers, jobs, they can be sexually neutral. And that is not a disorder. It is not a dysfunction. It is just a state of being for a woman. The way women experience fantasy and desire is very different from a man. They might experience desire, but the body might not be reacting to it, so that is okay. Women do not need to experience orgasm to have satisfactory sexual lives. And this particular model talks about intimacy. So when a woman has desire and then feels aroused, she can do so in the concept of trying to feel intimate with their partner, and that is satisfying. So, so I think that was an important distinction that this particular model made. After that, we come to WHO definition of sexual health. It talks about not just the absence of dysfunction, it talks about mental, physical, social well-being. Also, if you go to their website, they talk about safety, they talk about respect and absence of discrimination and coercion if you are in a healthy sexual relationship. Also, it's very interesting because they talk about sexual rights. So that was good. WHO has been working on this since 1970s, and the current definitions were proposed in 2006. I think this is important because of the trauma that a woman or a man faces in intimate partner violence. 1 in 4 women and 1 in 9 men go through some form of intimate partner violence, which can be a form of intimidation like stalking all the way to homicide. WHO does address that, and I think that plays a major role in how women experience their sexual function, and men as well. Then we talk about the 1992 National Health, Social, and Lifestyle Survey. This was colloquially called the Sex Survey. It was the first of its kind that was done nationally, and it found for the first time that women were reporting more sexual dysfunction than men. 43% women reported sexual dysfunction as opposed to 31% men. Then the article talks about the neurobiological aspects. Now we are going through various categories of how the sexual health is affected. So we'll go to neurotransmitters and sex steroids and how the reproductive events are affected as a result of that. When a girl reaches puberty, she's twice as likely to experience a mood disorder as opposed to a male of that age. Estradiol or estrogen is responsible for sexual desire and arousal. At this age, a girl is forming her identity as a sexual being and is being introduced to sexual desire. They talk about the role of estradiol in menopause. Decrease causes vaginal dryness, atrophy, dyspareunia. Then talking about testosterone. Testosterone is, if we look at the concentration or the levels of testosterone, from age 20 to age 50, there's almost a 50% decline. But prepubescent, there is an introduction of increase in testosterone, and that leads to initiation or increased sexual libido. Folks with low testosterone levels will experience dysphoria. Folks with androgen deficiency, also dysphoria, fatigue, and not receptive or initiating sexual activity. They also talk about androstenedione and androgen. One of the adrenal glands excretes this. So the thought is that not only is the ovarian menopause a factor, also the adrenal glands are playing a role. We talk about prolactin. When a woman is breastfeeding or there is hyperprolactinemia for whatever reason, there is a lower sexual activity, there is an increased sexual dysfunction likely due to decreased estrogen. Although oxytocin is high when a woman reaches orgasm and leads to more intimacy. Dopamine is a factor in desire, motivation, pleasure, as well as the cognitive experience of the sexual response. Also keeps the person focused on the activity. Norepinephrine is responsible for arousal. And during ovulation, there is a spike in testosterone at ovulation. And then before the ovulation, there's a spike in estrogen, so there's an increase in sexual desire. However, in the luteal phase, there is a decrease in estrogen and increase in progesterone, and hence a girl or a woman is susceptible for PMS or PMDD. The reproductive endocrine events. Now we switch to the reproductive years of a woman, an increase in estrogen, progesterone, and testosterone, hence an increase in desire. If a girl or a woman is engaging, this is what the article said, sexual activity more than once a week leads to regular menstrual cycles as well as ovulatory cycles. During the reproductive years, one of the things that affects the sexual response is the fear or the desire of pregnancy as well. So that becomes a big factor. Oral contraceptive use, decrease in estrogen can lead to high availability of sex hormone binding globulin, and hence a decrease in free testosterone. Or some women experience dyspareunia. But the biphasic or the triphasic oral contraceptives do not seem to have any different effects. After that, we talk about pregnancy and postpartum. A huge surge in estrogen and progesterone, hence leading to different mood swings. The body is going through a lot of changes. The woman's self-image is changing through pregnancy as well, and that would affect sexual function. And after the parturition, there is a decline in estrogen and progesterone. Hence, you're going from a surge to a deep decline, and there can be the postpartum depression, and hence affecting the sexual function. Decrease in estrogen can lead to fatigue. There can be fatigue due to anemia or thyroid dysfunction after parturition as well. The woman has gained a new role as a new mom. There is no privacy. There is intimacy with the child, maybe not as much intimacy with the partner. So there is distress related to the relationship as well. In terms of the type of delivery, a vaginal delivery that with instrumentation leads to a higher sexual dysfunction versus the cesarean section, which is the least in terms of sexual dysfunction. If a woman engages in sexual activity within the 12 weeks of parturition, if a woman does not engage in sexual activity within 12 weeks, she will experience dissatisfaction at 1 year postpartum. And this is when a woman is the most vulnerable for a hypoactive sexual desire disorder. This was the name used earlier, but now we'll talk later that DSM-5 has a new name for us. Then comes the menopausal transition. The average age for menopause in America is 51 years old. It can last from 2 years to 15 years. Women are 2 to 4 times more susceptible for depression during this time. Hot flushes, the deepening of the voice, and facial hair can lead to changes in how the woman is viewing herself and maybe not finding herself attractive. Decrease in estrogen, as we know, leads to the decrease in lubrication, vaginal atrophy and stuff. There was a study done called the SWAN study of women's health across nation. They found that 5% of the perimenopausal women, and I think this is a low number, had sleep disturbance, depression, or some sort of sexual dysfunction. So I think it's definitely more than 5%. This is also when a woman or a man, they become a perimenopause at both ends. They are taking care of kids. Is something wrong, Christina? Can you hear me? Hello?
Anyone can hear us. Hi.
Oh, yeah.
I don't know
can
that
hear
it
you
just
now.
cut out for a second.
Oh, okay.
Okay.
Yeah, I looked at your expression. I was like, what happened?
Thanks.
Okay.
Yeah, no, we'll edit this out later, so
Okay.
no problem.
Alrighty. So the SWAN study, the study of women's health across nation, we talked about that. And then, this is the time when perimenopausal women are part of the sandwich generation. They're taking care of kids at one end, and then probably taking care of ill parents or in-laws. And that leads to fatigue, relationship distress, and hence probably putting the women at risk for sexual dysfunction. Post-menopause, there was a study done, SAGE study, came out of San Diego, successful aging evaluation. This was 606 elderly folks. The average age was 72. I think it ranged from 55 to 99. And this study showed that 80% of the folks had some sort of sexual activity in the last 1 year. 70% had some sort of sexual activity in the last week, and 60% had either so-so or very good sexual life. They were satisfied. And this was the first of its kind survey that was done for that age group. And an interesting correlation came out that sexual dysfunction in that age group was not being affected by age, stress, anxiety, or physical ailment. However, depression played a big role, and depression was leading to sexual dysfunction. After that, we talk about definitions, the changes that have come about with DSM-5. The hypoactive sexual desire disorder has been taken out of the female diagnosis. It is now called the male hypoactive sexual desire disorder. For females, it is the female interest and arousal disorder. The vaginismus and dyspareunia have been clustered in genitopelvic pain or penetration disorder. And sexual aversion disorder has been deleted. These symptoms, unless it is a medication-induced or substance-induced diagnosis, the symptoms have to be there for at least 6 months. And the subclassifiers are they can be lifelong or acquired, or they can be generalized or situational. In terms of epidemiology, PRESIDE study, and this is confusing because there's another famous PRESIDE study that came out for prostate cancer. So when I was looking up, I was like, lots of prostate stuff. So it is the prevalence of female sexual problems associated with distress and determinants of treatment seeking. And this study looked at sexual function, sexual distress, and depression with PHQ-9. And 50,000 surveys were sent out to women. Of them, 31,000 responded. And it was, the average age was 49 years old. Although in terms of demographics, 81% I think were Caucasian, 58% had a higher degree than high school diploma, more than 50% were employed. But in terms of sexual dysfunction, 44.2% women reported some sort of sexual dysfunction. Of them, the highest was problems with desire, then arousal, and the lowest numbers in achieving an orgasm. Of the sexual dysfunction, 22.8 reported having distress because of that. And the highest distress was in the age group 45 to 64. And this seemed to be an attribute of having conflict with the partner or stress because of the expectations from the partner. And this decreases after the age group of 64 because either the partner has become physically ill or there is a loss of some sort of partnership or a change or a divorce. So this was quite interesting. 40% of the folks with sexual dysfunction had major depressive disorder. And then it was also found that women who had been treated for major depressive disorder, 13% were taking antidepressants. So they seem to have lower sexual dysfunction. So the bidirectional codependence or association between sexual dysfunction and depression was also eminent here. After that, we go to the medical problems and medications. Various medical illnesses can affect sexual function. Of them, cardiovascular disease and diabetes mellitus seem to be important. If you are a diabetic, you are 2 or 3 times likely to be depressed. So let's say you are diabetic and you are depressed. You're probably not taking that good care of yourself, poor glycemic control leading to complications, and hence further risk for sexual dysfunction. Also, sexual dysfunction can be a direct result of neurological disorders, pelvic disease, and various endocrine disorders. Medications, there is a long list of medications in the paper, but I'm just going to name a few. So statins, decrease in cholesterol, decrease availability of sex, steroid hormones, and also rhabdomyolysis leading to fatigue. Antihypertensives, I just realized diuretics cause a decrease in zinc and hence a decrease in testosterone. Of course, H2 blockers leading to erectile dysfunction, and the association of ibuprofen with a decrease in testosterone. This got a lot of press because the tabloid in England, The Sun,
Excuse me.
bless
Sorry.
you,
Oh my gosh.
bless you. The tabloid in England, The Sun, published a big headline saying ibuprofen is causing young men to be impotent. That caused quite the stir, but then there was a study that came out to refute it. But still, NSAIDs are on the list here in the article where folks will be at risk. After that, we talk about the bidirectional association of depression and sexual dysfunction. The article talks about the financial burden of depression on the society. But when I tried to look up the financial burden of sexual dysfunction, I kept coming up with the erectile dysfunction and how that was affecting. But there's nothing available, at least I couldn't find anything for female sexual dysfunction thus far. So I think that would be interesting when that comes out. There was a meta-analysis done in 2012 by Atlantis and Sullivan, where they looked for the risk for sexual disorder in depressive patients and vice versa. They had 6 prospective cohort studies for folks with depression and hence studying for risk for sexual dysfunction and vice versa. So 6 and 6. The weakness of the study was that they did not assess for the severity of the sexual dysfunction. So we don't know how that was affecting the depression. But if you were depressed, you were 50 to 70% at risk for sexual dysfunction. However, and these numbers are staggering, if you had sexual dysfunction, you were at 130 to 210% for depression. So that was a correlation that was found. After that, the article switches to screening and treatment. It is recommended that every time a woman goes through a change in a reproductive or a social status change, medication, illness, she should be screened for sexual wellness. Also, the partner should be screened if there is some sort of sexual dysfunction. And then it talks about the various medications, as we know, the psychotropics with the possible side effects of sexual dysfunction. It's recommended to use bupropion and buspirone for mitigating those side effects. And then the newer serotonin modulators, vortioxetine and vilazodone, Brintellix and Vibride, with lesser side effects are recommended. They talk about hormone therapy being used for sexual dysfunction. And then the FDA approved for postmenopausal dyspareunia medication, Osphena. It is a selective estrogen receptor modulator, specifically works for vulvar and vaginal atrophy. So this is one of the FDA-approved medications. And then 25 years after Viagra was approved for sexual dysfunction in men, we finally had the FDA approval for hypoactive sexual desire disorder in women. This is for premenopausal women. It is a multifunctional serotonin agonist and antagonist. The brand name is Addy. The generic is flibanserin. It is a one-time 100 milligram dose. A new warning came out on April 11th, last month. FDA wants the manufacturers to caution the patients. If Addy is to be taken with alcohol, there is a risk for life-threatening hypotension. So that's why it is recommended to take it at night, because your blood pressure is going down anyway. So this is the FDA-approved medication for premenopausal women. However, if there is a relationship conflict and an obvious change in life or illness that has caused the hypoactive sexual disorder, then this is not to be prescribed. After that, we have studies galore for adjunctive testosterone therapy. We have, I think, 4 studies that the paper talks about for postmenopausal women, and then a couple for premenopausal women. Davis et al. Studied, and the general consensus is that 300 micrograms transdermal application was effective in 2 of the studies. One did with placebo, and the other one did it with estradiol. So 300 micrograms was effective. The premenopausal, there were studies done in 34 women with decreased libido, and 1% testosterone cream was found to be helpful. There was another study done with testosterone spray, 90 microliters, one-time spray instead of 2 times, and then instead of 56 microliters or placebo, one-time 90 microliter spray was helpful. There is also a mention of intramuscular testosterone for postmenopausal women, which might be useful. However, NAMS, National American Menopausal Society, the Endocrine Society, and the British Society for Sexual Medicine, all of them have put out statements saying that testosterone should be used with caution, and it should be patients should not be at risk for fetal exposure, or also keeping in mind that hirsutism and dyslipidemia are side effects. However, one of the 3 irreversible side effects are male pattern baldness, hoarseness of the voice, and the enlargement of the clitoris. So women have to be informed of that. After that, it talks about the systemic estradiol and progesterone use. Psychotherapy is recommended. Also, the British Society for Sexual Medicine talks about tibolone. It's not tibolone, that's a typo in the article. It's tibolone. It's a synthetic steroid that basically breaks down and functions as an estrogen, progesterone, and testosterone molecule. So that is recommended. Of course, the systemic estradiol progesterone therapies in older women can carry various risks, significant risk of like blood clots, some types of cancer, cardiovascular problems, and dementia when initiated in older women. So the conclusion is that we should be mindful of the different stages that a woman goes through, what the biopsychosocial, cultural, religious teaching has been, and how the various changes are affecting the sexual function. Screening is important, and we have the new FDA-approved medication as 2 of them, and the various factors like neurobiology, neuroendocrine function, and the association with depression should be also taken into account. So yeah, that's it.
Well, thank you. That was great. We did have one question about if you have any clinical experience with ADI, and what is the common consensus on its utility?
So I think that's a question from Vikas. Vikas is my senior from medical school. Hi, Vikas.
Oh.
Because I do not have any experience with ADI. As you know where I work. California Corrections Men's Facility. So no, I do not. But studies show that it is prescribed as 100 milligrams dose, and one of the side effects is hypotension. But I don't know what the efficacy is. So yeah.
Yeah, the only thing I know, because I'm at the VA, so I also have not had any opportunity to use it. But the only thing I know is that the FDA updated the warning about its interaction with alcohol, and so it's not a strict contraindication anymore. Yeah. So, but that's the only thing I personally know. So yeah, I'd love to hear if it actually works, or if people are starting to use it. If anybody has used it with your patients, feel free to comment. That would be great to hear about. But yeah, otherwise that was a great summary, and I learned a few things that actually I did not know. And
so did I.
I probably don't screen for sexual functioning and sexual health as much as I should, even though I've been taught to. So just because other things seem to always take priority, but certainly it can be an important part of someone's overall well-being. So
yeah, especially when sexual dysfunction can lead to depression. In terms, the numbers are like 130 to 210%. So
and it's all connected. So okay, well, thank you again for joining us and for all your efforts. This is, I believe, your 3rd video.
It's my 4th video.
4th. Oh my gosh! So I think you lead the number of videos that anyone has done. You've done like 10% of our videos. So yeah, thank you again. And next week, join us, you guys, on Thursday night for the last one. And yeah, we'll have to decide what our group is going to be doing next after the conclusion of this project. So
I'm excited for the conference.
Yes, the women's conference is going to be great. And anybody who is still thinking about signing up, it's not too late. Feel free. You can always find the information. You can always send me a message, but it's on the website, Psychiatry Network, etc., etc.com. So yeah, it's going to be really fun. So, all right, guys, we'll see you next time.
All right, bye.
Take care. Bye.